prelim, midterm, and term. Prelim. Discussions in prelim, we have 4 clinical classifications. And these are ownership, function, institutional character, and service capability. First, ownership. Under ownership, we have government and private. In government, it is operated and maintained partially or wholly by government. In private, it is owned, established, and operated by any individual, corporation, association, or organization. Second, we have function. Under function, we have clinical pathology and anatomic pathology. Under clinical pathology, we have here CC, Hema, Immunohema, Micro, Immuno, CM, Intoxi, Molecular Biology, Cytogen, TDM, and etc. And under anatomic pathology, we have surgical pathology, immunohistopathology, and cytology, molecular pathology, autopsy, and forensic pathology. Next, we have institutional character. Under this, we have institution-based and freestanding. Institution-based, these are the laboratories that operates within the premises and as part of an institution, such as but not limited to the hospital, medical clinic, school, medical facility for overseas workers and seafarers, birthing home, psychiatric facility, and drug rehabilitation. Freestanding, these are the laboratories that does not form part of any other institution. Next, we have service capability. Under service capability, we have primary category, secondary category, and tertiary category. Primary category, we have here routine for hematology, qualitative platelet determination, routine for urinalysis, stool exam, and BT for hospital base. Secondary category, we have primary category plus the routine clinical chem, cross-matching, GRS, KOH for the hospital base. And last, we have tertiary category. Under this, we have primary plus secondary plus special chemistry, special hema, immunology, microbiology, and CIS. Next topic, we have the laboratory science profession. Laboratory science, the medical discipline by which clinical lab science and technology are applied to the care of patients. This profession is not recognized not until early 20th century. In the laboratory, testing dates back to ancient times. Early tests is done on urine. That was 19th century chemistry laboratory. Next, we have the early history of laboratory science. Early physicians in ancient Egypt and Mesopotamia based diagnosed and treatments on observation of clinical symptoms. Also began the practice of examining patient specimens. Oldest known test on body fluids done on urine. Hippocrates developed early diagnostic protocols related presence of bubbles on the surface of the urine results as kidney disease. Egyptians described and managed urinary symptoms. First mention of hematuria, blood in urine, around 50 BC by Rufus of Ephesus, thought to be associated with schistosoma and stones. And the early history continued. Here we have the Middle Ages. Next, we have the 17th century laboratory science. Nineteenth century advances in bacteriology. Next, we have 19th century advances in hematology. Laboratory science in the 20th century. Various types of labs began to emerge, like physiological, pharmaceutical and pharmacologic, forensic, public health, microbiological, and general hospital labs. 20th century developments in microbiology. In early 1900s, microbial growth factor is discovered. The arrival of antibiotics. Alexander Fleming discovered penicillin, and he found a mold that could prevent growth of Staphylococcus. 20th century clinical chemistry. We have Otto Follin and Donald van Slyke. 20th century developments in blood banking. In 1932, first blood bank established in a Leningrad hospital. In 1937, first hospital blood bank established in the US. Charles Drew and Karl Landsteiner. Next, we have the quality movement in the laboratory. '16th century. Spanish Empire occupied Luzon, established Manila as a capital. Pioneers. Next, we have the PAMIT presidents. Hippocrates, let food be the medicine, and medicine by the food. Medieval period. 17th century. We have Anton van Leeuwenhoek, first scientist to observe and describe RBCs and to differentiate bacteria. Malpighi, the greatest of the early microscopists and the founder of the microscopic anatomy. Rodolph Virchow, the father of pathology. Dr. Douglas established the first chemical laboratory at the University of Michigan. In 1896, Dr. William Oster opened the first clinical laboratory at Johns Hopkins Hospital. William Welch, the father of the American pathology. He set up the first pathology laboratory in America at Bellevue Hospital. He is the first professor of pathology at Johns Hopkins University. Dr. James Studd. He wrote the Manual of Clinical Diagnosis, which is the new clinical diagnosis by laboratory methods in 6th edition with Dr. Arthur Sanford. There was a demand for technicians in clinical laboratories during the World War I. University of Minnesota was the first to offer a degree program in medical technology in 1927. During World War II, the use of blood increased and the closed system of blood collection was widely used. Instruments was advanced. Karl Landsteiner. Isaac Judaeus. The Jerusalem Code. William Harvey. Richard Lower as animal-to-animal blood transfusion development. Jean-Baptiste Denis, animal-to-human blood transfusion development. James Blundell, human-to-human blood transfusion development. Jules de Bosca developed the first visual colorimeter based on the Beer's law. Louis Pasteur, the pasteurization. Robert Koch, PTB and cholera. Alexander Fleming, penicillin. The era of public health is in 19th century. John Snow studied cholera in London. Midterm.
Biosafety, the containment principles, technologies, and practices that are implemented to prevent unintentional exposure to pathogens and toxins or their accidental release. Laboratory biosecurity, the protection, control, and accountability for valuable biological materials within laboratories in order to prevent their unauthorized access, loss, theft, misuse, diversion, or intentional release. Biosafety protects people from germs. Biosecurity protects germs from people. Risk Group 1, a microorganism that is unlikely to cause human or animal disease. No or low individual and community risk. Risk Group 2, can cause human or animal disease but unlikely to be a serious hazard to laboratory workers, the community, livestock, or the environment. Effective treatment and preventive measures are available. Risk of spread of infection is limited. Moderate individual risk, low community risk. Risk Group 3 usually causes serious human or animal disease but does not ordinarily spread from one injected individual to another. High individual risk, low community risk. Risk Group 4 usually causes serious human or animal disease and that can be readily transmitted from one individual to another, directly or indirectly. Effective treatment and preventive measures are not usually available. High individual and community risk. What is the difference between biosafety cabinet and a fume hood? Fume hood, no filtration of air, exhaust chemical fumes outside the laboratory, suitable for chemicals and non-sterile work. Biosafety cabinet, HEPA filtration of air intake and exhaust, recirculates filtered air into a laboratory, utilized to ensure sterility, cell culture, and containment of infectious work. Biological safety cabinet is a form of an engineering control that is used throughout the microbiology laboratory, portable safety station for handling of aerosols and particles, and provides laboratory personnel protection. Class 1 Biosafety cabinet, exhaust, HEPA filter, and air. Class 2 Biosafety cabinet, exhaust, HEPA filters, and air. Class 3 Biosafety cabinet, exhaust, filter, and gloves. Biosafety Level 1 Bacillus, Subtilis, and Naegleria groberi, agents that are well classified and are not known to cause disease. Consistently healthy adults pose minimal threat to laboratory personnel and the environment. Biosafety Level 2 HBV, HIV, Salmonella, SPP, and Toxoplasma SPP, agents that pose a moderate potential hazard for the employees and the environment. A typical Biosafety Level 2 laboratory. Biosafety Level 3 M. Tuberculosis, St. Louis encephalitis virus, and Coxiella burnetii, required for infectious agents that are either indigenous or exotic, have the potential for aerosol transmission, and have serious lethal consequences. A typical Biosafety Level 3 laboratory. Biosafety Level 4 Ebola and Congo Cremen hemorrhagic fever, required when working with agents that are dangerous and exotic, have a high risk of causing life-threatening infections, can be transmitted by aerosols, or have an unknown risk of transmission. Biorisk, risk associated to biological toxins or infectious agents. Biorisk management, the integration of biosafety and biosecurity to manage risk when working with biological toxins and infectious agents. 3 primary components. Risk assessment is a careful examination of the premises, processes, and work activities to identify what could cause harm to people and to enable decisions to be made as to whether sufficient precautions have already been taken or whether further controls are needed. Hazard refer to potential for something to cause harm, substances, machinery, energy, or particular operation. Risk, a combination of likelihood or probability that the hazard will cause actual harm and the security of the consequences. Hazard or threats, steps risk assessment. Mitigation procedure. Measures are actions and control measures that are put into place to reduce or eliminate the risk of association with biological agents and toxins. 5 major of control or measures. Blue, elimination, physically remove the hazard. Green, substitution, replace the hazard. Yellow, engineering controls, isolate people from the hazard. Orange, administrative controls, change the way people work. Red, PPE, protect the worker with personal protective equipment. Performance evaluation. Performance management is simply reevaluation of the overall mitigation strategy. Infection control, an all-encompassing program that is headed by a committee responsible for making policy and providing ongoing surveillance of all aspects of hospital operations. Infection control standard, precautions in healthcare to reduce risk of transmission of blood-borne pathogens, infection, the invasion of multiplication of any organism that has potential to harm the body of a human or other organism. Category 1 workers, subject to the potential for exposure to infectious agents, toxins, and materials. Example. Category 2 workers, incidental to the nature of their duties, these workers may be exposed. Example. Category 3 workers, seldom or ever subject to exposure. Example.
And last, enter. We have here clinical chemistry, microbiology, clinical microscopy, hematology, immunology, and serology. In clinical chemistry, we will be dealing about the measurement of amounts of biological important substances in body fluids. Next, we have microbiology. Microbiology is the study of microscopic organisms. Clinical microscopy. Clinical microscopy performs scientific analysis of non-blood body fluids. Hematology. Hematology is the study of blood-forming organs, and blood diseases. The tests include tests on the blood proteins, and blood-producing organs. Last, immunology and serology. Immunology is the study of immune system, wherein the immune system protects us from infection through various lines of defense. Serology is an examination of blood serum, especially with regard to the response of the immune system to pathogens or introduced substances. Next, we have blood banking. Blood banking is a process that takes place in the lab to make sure that donated blood or blood products are safe before they are used in blood transfusion and other medical procedures.